Good evening, everyone, and thank you, Rick, and thank you, Ami, for the nice introduction. I'm so pleased to do this first inaugural talk of our global pediatric lecture series. And I'm going to be talking today on management of hypoglycemia in neonates and children. And so just to start off with, we all know glucose is an important fuel for the brain. And if the brain is deprived of the glucose, then children can get brain damage. And that is why it's crucial to manage hypoglycemia appropriately. We know the brain can use alternate fuel like lactate and ketones, and hypoglycemia causes brain damage. And there has been many studies and case reports which have shown that hypoglycemia, when it is persistent or severe and it's not managed appropriately, can lead to long-term neurodevelopmental issues. And this is a study in a group of children with congenital hyperinsulinism, who have been subsequently known to develop quite a significant proportion known to have neurodevelopmental problems due to that early hypoglycemia. So just a little bit background of physiology about how the glucose homeostasis works. So our blood glucose is maintained in a very tight normal range on a daily basis, and the blood glucose is used for various metabolic pathways, including glycolysis and glycogenesis and fat synthesis. And when we fast or when we don't have foods, then the blood glucose gets released from the stored glycogen in the muscle and the liver. And also new glucose is formed from the breakdown of protein and fat. And this process of blood glucose utilization is controlled by insulin, and the blood glucose production is controlled by glucagon, the two crucial hormones which come from the pancreas. So the glucose homeostasis depends on an adequate supply of the fat, glycogen, and the gluconeogenic substrates, an intact enzyme system for running all these metabolic pathways, and also a normal endocrine system for putting all these systems together. So what happens just after birth? We know all babies have a tendency to drop the blood glucose after birth, which is normal and physiological. But once they have the feed, the blood glucose comes up, or the alternate mechanisms and the catecholamine surge and glucagon surge happens, and the blood glucose levels start coming up. And this metabolic adaptation can be compromised in a group of high-risk babies, which includes babies who are born to mothers with diabetes during pregnancy, preterm and IUGR babies with birth hypoxia, sepsis, and also certain syndromes like Beckwith-Wiedemann syndrome, which is classically characterized by macrosomia, examphulus, large tongue, ear creases, and some of these babies also do have hypoglycemia at birth. The hypoglycemia can be transient, but some of them go on to develop hyperinsulinism, which can be quite tricky to manage. So how do you define hypoglycemia? What is the cutoff? What is the magic number above which the blood glucose is normal? So there's a lot of debates all the time about the cutoff to be used, but the thing to remember is it's not about just one single blood glucose value. It's about the whole picture of how well or unwell the baby or the child is. A baby who is asymptomatic with a slight borderline glucose may be doing well when compared to a baby who has recurrent hypoglycemia with a background of other risk factors. Traditionally, we use a cutoff of 2.6 millimole or 50 milligram per deciliter to act on the blood glucose. The American Paediatric Endocrine Society recommends using a cutoff of 2.8 for babies less than 48 hours and 3.3 for babies more than 48 hours. But what we know for sure is in babies who are suspected to have metabolic problems like hyperinsulinism, we recommend then keeping a higher cutoff like 3.5 millimole or 63 milligram per deciliter. Because we know in these situations, due to the high amount of insulin, the glucose is low, but also the ketones and the alternate fuels are low as well. So what happens when somebody undertakes a fast? So initially the glucose gets released from the food, and once that's all exhausted, then the stored glycogen from the liver and the muscle breaks down and releases the glucose. And the next step is gluconeogenesis, where new glucose is being produced from breakdown of protein. And the last thing to happen is the fatty acid oxidation, where it's a breakdown of the fats into ketones and fatty acids. There are a number of different causes of hypoglycemia that ranges from a number of endocrine conditions to several metabolic problems. And the common things you might come across as pediatricians, if you come across somebody with repeated episodes of hypoglycemia, is congenital hyperinsulinism. Adrenal insufficiency or pituitary problems can present with hypoglycemia, and then metabolic problems like glycogen storage disorder and fatty acid oxidation defects, liver failure, And in toddler, older children, idiopathic ketotic hypoglycemia is not uncommon. And in some group of children with underlying problem like gastrointestinal issues, postprandial hypoglycemia could happen as well. So just to get the metabolic causes out of the way, defects of fatty acid oxidation, glycogen storage disorders, and defects of gluconeogenesis can present with hypoglycemia, but usually with other features like acidosis and high lactate. And that's a comprehensive list of metabolic investigations which may be initiated at the early stage, and you will be subsequently discussing with the metabolic experts to make further plans. The symptoms could be very variable. If you look at that picture, you may feel a little bit dizzy, and that's how older children or adults with hypoglycemia feel when they have an episode. And the symptoms could be anything from poor feeding to lethargy to seizures and coma. So we know that in any unborn child, we should definitely check a blood glucose. The signs to look for when you're dealing with a baby with the hypoglycemia, look for macrosomia, any dysmorphic features, and jaundice, small phallus, undescended testes could point towards a hypopituitarism, skin pigmentation, look for hepatomegaly for metabolic issues, and cardiomyopathy. So what are the key investigations to do? Now, when you deal with a child or a baby with hypoglycemia, the key thing is to take all the samples, which will tell us later why the hypoglycemia happened in the first place. So it's important to take the critical sample first before we act on the hypoglycemia. So the key investigations include blood glucose, insulin, cortisol, fatty acids, and 3-hydroxybutyrate, which is the ketone we measured in the lab. The ones in the red are essential investigations during hypoglycemia. If possible, we can also take samples for growth hormone, carnitine, acylcarnitine, and ammonia lactate and gas. If you get a urine sample, urine ketones and reducing substances and organic acids would be good. And if you're able to do bedside ketones, that will be really helpful in differentiating the causes of hypoglycemia. Now, if we are unable to take the full hypo screen, and if you have to tackle the hypoglycemia, then we have to definitely do that. But subsequently, then we can revisit and undertake a controlled fast to identify the cause of hypoglycemia in some of these patients. We also do in our unit special tests like prolonged OGTT or mixed meal or protein load based on the clinical circumstances to identify the cause for the hypoglycemia. So this is a mini algorithm to look at how to go about when you tackle hypoglycemia. The key thing to understand is whether it's ketotic or non-ketotic. So that's the crucial bit. And once you're in a situation where there are no ketones, then you look at the right side of the pathway where we look next at the insulin level. And if insulin is detectable, that's abnormal. Now during hypoglycemia, your pancreas should switch off and insulin should be absent. And any detectable insulin is abnormal, and that will suggest a hyperinsulinism situation. Now, let us say insulin is not detectable, then you look at other conditions like fatty acid oxidation defects, and urine organic acids and acylcarnitine profile will help to diagnose that. Let us say you see plenty of ketones during hypoglycemia, then you look at the lactate levels. If they're raised, that could suggest metabolic problems like glycogen storage disorders. And if the lactate is normal, then you think of endocrine conditions like growth hormone deficiency and cortisol deficiency. And once we have ruled out the known causes, then we make a diagnosis of idiopathic ketotic hypoglycemia. So I'm going to go through a few cases to understand this a little bit better. So the first case is a term baby born with a birth weight of 3 kilograms and was felt to have male genitalia. The gonads were not palpable. And the baby was discharged home and registered as a male baby and comes back in 2 weeks' time with vomiting, hypoglycemia, hyponatremia, and high potassium. And now the genitalia has been noted to be abnormal. And in this situation, obviously, we are thinking of an adrenal problem. So we will do further investigations, including cortisol, ACTH, and if needed, then we'll undertake a synactin test. And the other investigations like 17-OHP, androgens, to look for the cause for hypoglycemia and also the electrolyte problem, in this case, which is most likely to be due to congenital adrenal hyperplasia. If possible, a urine steroid profile will be useful, again, taken before starting any hydrocortisone treatment, and a karyotype and ultrasound pelvis will be important. And to understand adrenal insufficiency, we broadly divide them into primary and secondary. Primary, where there is a problem within the adrenal gland per se, and the ACTH levels tend to be quite high. Now, this could be congenital or acquired. Congenital includes congenital adrenal hyperplasia, like the patient we just discussed, or occurred. The most common cause is Addison's disease, which is the autoimmune adrenal insufficiency, or other conditions like sepsis. Secondary adrenal insufficiency is due to the problem with the pituitary or hypothalamus. So your ACTH is here normal or low. And the congenital secondary adrenal insufficiency is due to conditions like hypopituitarism. And the occurred causes includes conditions like brain tumors, radiation, surgery. And most common cause is obviously use of exogenous steroids for various conditions that can cause suppression and produce a secondary adrenal insufficiency. And this is a steroidogenesis pathway, which I'm sure you all will be familiar about. And this, in the CAH, the most common enzyme defect is 21-alpha hydroxylase, where there's a block at this level. So we have increased levels of the precursors, including 17-OHP, and the androgens, causing the virilization in an XX karyotype. And that leads to reduced cortisol and mineralocorticoids. And the management includes fluid resuscitation, dextrose bolus to manage the hypoglycemia, and hydrocortisone bolus followed by maintenance hydrocortisone. And we would subsequently start these patients on fluid cortisone and sodium supplements. And in terms of the genitalia related issues, and we'll have to discuss with the GSD team to make further plans. Moving on to the next patient is a baby who was born at 36 weeks with a birth weight of 2.3 kilogram, noted to have a small phallus at birth. The testes have been bilaterally undescended, and jaundice was noted on day 3, and the baby needed some phototherapy. Noted to have apneic episodes on day 8, and the blood glucose was noted to be low, 1.5 millimoles or 27 milligrams. So further investigations were undertaken, and here we are thinking of, given the clinical picture, a pituitary problem. So we are undertaking further investigations that include thyroid function, gonadotrophins, and also urine and plasma osmolality and fluid balance. And once the hypopituitarism is diagnosed, then the treatment includes replacing the hormones. And as pituitary gland produces few different hormones, it's important to be aware how we replace these hormones in a certain order. It's always important to replace the hydrocortisone first before starting other hormones. And once the hydrocortisone has been started for 48 hours, then we can start thyroxine after that. Because if you do the other way around, then thyroxine will increase the metabolic rate and will increase the risk of adrenal crisis. The other thing to remember, once you start hydrocortisone, sometimes it can unmask the DI. Now, diabetes insipidus could be masked because of adrenal or cortisol deficiency. And once we start treatment, we can see sometimes that the urine output increases and the DI becomes obvious. And it's important to be aware of that. Growth hormone will be usually started later. So the first year or two of life, the growth depends on the nutrition. So we don't really jump into starting growth hormone. And that's something you'll end up starting later on based on the progress of the growth of the child. Moving on to the next patient is a 3-year-old girl who presented with diarrhea and vomiting for a couple of days, looked very drowsy and dehydrated. And this may be a familiar scenario for all of you. And the blood glucose again was checked, was very low, 1.8. Ketones were checked and there was 3+. So as you can see here, there's plenty of ketones on board. And now thinking about our pathways, now we are going down the direction of the ketotic hypoglycemia. Cortisol levels are normal, insulin is suppressed, and the metabolic investigations are normal as well. So this leaves us with the diagnosis of idiopathic ketotic hypoglycemia, which is not uncommon at all in toddler age groups when these children present with intercurrent illness. So it should be a diagnosis of exclusion, but sometimes what you may see, some of these children do present with persistent or repeated episodes of this ketosis. You might occasionally see a postprandial ketosis, or if there is a high lactate or hepatomegaly or short stature, those should be the pointers to think about underlying metabolic problem in a small number of children who present with ketotic hypoglycemia, who could have metabolic problems like glycogen synthase deficiency or glycogen storage disorders. And moving on to the next patient is the baby who was born with the birth weight of 4.5 kilos, irritable on day 1 of life, and blood glucose is low, 1.1 millimoles or 20 milligrams, as you could see. So hypo screen was undertaken, and as you can see, insulin is detectable. It's high, actually. So that's clearly abnormal. So this is a hyperinsulinemic situation. And because of the high insulin, fatty acids and ketones are suppressed in this patient. And the growth hormone and cortisol levels are normal. So this is the typical situation of congenital hyperinsulinism, which used to be called in the past as PHHI. And this is a commonest cause of recurrent and persistent hypoglycemia in infants and children. They usually present in the neonatal period, but some of these children can present later as well. They can present with epilepsy or seizures and in later childhood or with developmental delay. How do you diagnose this? As we just saw, the biochemical picture will help us to make the diagnosis. And the other key measure is the glucose infusion rate. So a normal glucose infusion rate for most babies will be around 4 to 6 milligram per kilo per minute. And when this goes up, in the sense that to manage a hypoglycemia, you have to give more and more fluid volume or high concentration dextrose, which will increase the glucose infusion rate. And that goes about 8 or 10, then you start suspecting hyperinsulinemic situation. And you will also see a suppressed ketones and fatty acids. Very rarely, insulin may not be detectable, maybe due to sample assays or how the sample gets transported. But the whole picture, including high glucose infusion rate and suppressed fatty acid and ketones in a situation of persistent hypoglycemia, should help us make diagnosis of congenital hyperinsulinism. And that's the formula to calculate the glucose infusion rate. I'm pretty sure you're all familiar with this. So once you made the diagnosis, the next question is it a transient problem or is it going to be a long-term issue? And that's the question which comes to our minds as clinicians and also in the minds of parents, and they would want to know. So they could go either way. In the initial stages, it may be difficult to differentiate. So they could either be transient in the sense lasting for a few days to a few weeks. Sometimes transient can last up to a few months as well, or it can be a persistent long-term issue. And then we group these persistent patients into two groups, whether they are diazoxide responsive or diazoxide unresponsive. And the transient hyperinsulinism is more common in babies with underlying risk factors like IUGR, preterm babies, or certain syndromes as we discussed before. So if they have any underlying risk factors, it may give a little bit of clue to you that it probably is going to be a transient problem. So coming back to our patients, was managed with 10% dextrose bolus. Now for correction of hypoglycemia, it's always only 10% dextrose. We don't have to use anything more than that in terms of concentration. And once you have corrected the hypoglycemia, should always follow with a continuous infusion of glucose, starting with 10% dextrose. And if the blood glucose is still not coming up, then we increase gradually. And in this particular patient, we have to increase up to 25% dextrose. And once you go beyond 10% dextrose, the infusion should be running through a central line, not a peripheral line. And here the glucose requirement went up to 20 milligram per kilo per minute. And this is a quite tricky situation to manage because you're ending up giving a lot of fluids and a lot of high concentration dextrose. Sometimes you may come across issues with the central axis as well. In those situations, glucagon can come quite handy. So glucagon, you may be aware of being used in patients with diabetes for managing hypoglycemia as an AM injection. So the same glucagon can also be run as a continuous infusion, but through intravenous route. It can go through central axis, or it can be run peripherally as well. It can also be run through subcutaneous using a small cannula as a continuous infusion. And we start at a rate of like 5 mics per kilo per hour and build it up based on the need of the patient. And that will be very helpful in this situation because it will take the pressure off from the high concentration dextrose fluids to maintain the blood glucose in the normal range. And so the key thing initially is to stabilize the blood glucose. So once the blood glucose is nice and stable, then we can start the definitive treatment, because the definitive treatment includes oral medications like diazoxide, which will take a few days to come into action. So until then, it's important to maintain and blood glucose in the normal range. Now, diazoxide is started orally, and the thing to remember when you're starting diazoxide is to restrict the fluids to a maximum of 130 or 140 mils per kilo per day, because of one of the side effects of diazoxide being fluid retention, which is a major issue. And this total volume of fluids also includes the feeds. We always start a diuretic like chlorothiazide, but if you have to go up to high doses of diazoxide, we may switch to potent diuretics like furosemide and spironolactone. So the medical management, so starting diazoxide from 5 milligram per kilo, sometimes we do smaller doses as well in IUGR babies. And the maximum dose is up to like 15 or maximum 20 milligram per kilo per day. Use diuretics alongside the diazoxide. And also, it's very important to get an echocardiogram as a baseline before starting diazoxide, because babies with underlying cardiac problems may have an increased risk of side effects of diazoxide, and it may be important to avoid diazoxide in those situations. So the side effects include fluid retention, weight gain, electrolyte problems like hyponatremia, heart failure, And in long-term use, hypertrichosis, which is the excessive growth of pulmonary hypertension, is an issue as well in some patients, especially when the fluids are not restricted, or if they have an underlying cardiac problem, then pulmonary hypertension could be a big issue. And this is a series of patients we published from 3 centers in the UK, and the number of patients who ended up having pulmonary hypertension following diazoxide treatment. So once they respond to diazoxide, now you're starting with diazoxide orally, and then you're seeing the blood glucose being more stable, then you can start weaning down your intravenous fluids slowly. And once you stop IV fluids, if you're on glucagon, you can wean down and stop that as well. And alongside, you establish the feeds. And throughout the process, maintain the total volume of feeds and fluids as 130 or 140 mils per kilo per day. Once you're fully fed, then we know blood glucose is stable and diazoxide is working. Then we do undertake something called 6 to 8 hours safety fast. And that's important before sending the patient home, because then we know diazoxide is working absolutely well and the blood glucose is maintained normally before they go home. We give a clear hypo plan for parents to follow, we train them to check blood glucose 2 or 3 times at home before feeds. And if it is below the cutoff of 3.5 millimole, then we give training for the parents to manage the hypoglycemia at home initially using glucogel or feeds. And if that doesn't improve, then they come to the hospital. On some occasions, we might train parents to use the intramuscular glucagon injection as well for emergencies. And there are a number of resources in this website. So if the patient doesn't respond to diazoxide, let us say you increased up to 15 or 20, and you can't still wean down the IV fluids and the blood glucose is still borderline, then we are in a difficult situation. A small number of patients might end up in this situation. The question is then what we do next. So we follow this algorithm. So our next step is look at the genetic test here. So this is an interesting area where the genetics plays a crucial role in the clinical patient management pathway, because genetics can guide the management subsequently. So just to understand the genetics, it's useful to understand how insulin is released from the beta cells of the pancreas. So when we have something to eat, I'm sure you all would have had lunch or dinner, whichever part of the world you are at the moment. And once your blood glucose goes up, that's taken up into the beta cell, and the glucose undergoes glycolysis, enters into Krebs cycle. And as a net effect, we release ATP. That causes the potassium to move out of this channel, which is called potassium sensitive channel or KATP channel. And then once the potassium exocytosis happens, the channel closes, and there's a membrane depolarization. And that opens the calcium channels, and the calcium gets into the beta cells and then releases the insulin, which is already produced and stored within the beta cells. And that is what happens normally in everybody's body all the time. Now, in our patients who have genetic problem with some of these genes, and these genes ABCC8 and KCNG11 coding for the KATP channel on the beta cell membrane, if there's a defect in this gene, then the channel will not work properly. And what happens is this channel is constantly closed, so there's a constant depolarization and constant calcium influx and constant release of insulin from the pancreas, irrespective of the blood glucose levels. So it's not in relation to the blood glucose anymore. And that insulin causes low blood glucose. And that is what is the problem in some of these patients who do not respond to diazoxide and who have a severe form of congenital hyperinsulinism. There could be other genetic mutations like glucokinase, GDH, and HIDH also can cause similar picture. So far, these are the number of genes which have been implicated in causing congenital hyperinsulinism. And there's a gene panel available which can test all genes in one go. And FOXA2 is a gene which we described from Alderhey Children's Hospital from our research study using a whole exome sequencing, where we identified that children with congenital hyperinsulinism, along with hypopituitarism and midline defects, can have this FOXA2 mutation, and we reported that for the first time, and more patients have been described since with this particular mutation. And now it is part of the congenital hyperinsulinism gene panel as well. There are other rare forms of hyperinsulinism. Some patients, you might notice, along with hyperinsulinism, they have raised ammonia levels, and they have hypoglycemia not just in the fasting state, but also in the postprandial state, like post-meal. And that's triggered by the protein in the diet. And these patients might have epilepsy, and that's due to an interesting condition called hyperinsulinism hyperammonemia syndrome caused by the GLUD1 mutation. Fortunately, these patients do respond to diazoxide, and it's felt to be a lifelong condition. Although interestingly, recently we have published a patient who managed to come off the diazoxide treatment at 8 years of age. HNF4 alpha and HNF4 alpha, you might have heard of these genes in the context of MODY, maturity onset of diabetes in young, which is known to cause familial diabetes. Now, the same genes can cause hypoglycemia in the newborn period, mutations in these genes, and these babies tend to be large at birth. Usually, there is a family history of diabetes mellitus, and HNF4 alpha has been reported to cause hyperinsulinism, and HNF1 alpha recently we reported, along with our Manchester colleagues, it seemed to be causing congenital hyperinsulinism. And the interesting thing is these patients is they respond to diazoxide, they come off treatment when they are 5 or 6 years of age, but subsequently they switch and go on to develop diabetes in the adolescent or adulthood. So it's quite important to monitor them once the hyperinsulinism has resolved. So it's important to monitor them for the onset of diabetes in the later stage. So coming to the severe hyperinsulinism patients, there are two broad histological subtypes: diffuse disease, where there is a problem with whole of the pancreas producing too much insulin, or focal disease, where there's a problem within a small part of the pancreas producing too much insulin. And the diffuse disease, and this is when we get the genetic report that will tell us whether this is likely to be a diffuse disease or focal disease. And in severe patients who do not respond to diazoxide, the diffuse CHI is usually due to an autosomal recessive mutation in ABCC8 or KCNG11. Autosomal dominant mutations usually tend to respond to diazoxide. Focal hyperinsulinism has got an interesting genetic etiology. It's usually due to a paternally inherited ABCC8 or KCNG11 mutation, and the fathers will be asymptomatic. But what happens within the pancreas of the child, there is a second hit, and there is a loss of heterozygosity. So within that small lesion. And the focal lesion is usually less than a centimeter. And the important thing to remember is this is not insulinoma. So we should not get confused with insulinoma. Insulinoma is a benign tumor, which can also present with hypoglycemia, but usually in adolescents or adults, and could be part of MEN1. Now, focal hyperinsulinism patients, once it's identified, then removing the focal lesion will be curative for the patients. But before we do that, we need to know where exactly the focal lesion is in the pancreas. And that's why this PET CT scan using a special dye HMF DOPA helps to localize the focal lesion. And you can see the image of this DOPA PET scan where the focal lesion. So that's the outline of the pancreas, and you'll see the higher intake or increased uptake in the head of the pancreas. So we know the focal lesion here is in the head of the pancreas. Then the surgeons can go in and remove the focal lesion, curing the problem. Whereas diffuse disease, you will see the uptake is uniform throughout the pancreas, and this is a little bit more tricky to manage. So we have already tried diazoxide, it didn't work. So the next line of medicine is using Octotide, which is given as an injection 6 to 8 hourly. And the dose is anything from 5 up to 40 mics per kilo per day. You can use Octotide as continuous infusion, which we have tried sometimes. And usually this probably will be combined with using high-calorie diet or continuous feeds to manage the hypoglycemia. The problem with Octotide is the tachyphylaxis, because the response sometimes tends to wean down after using for a few weeks to months. The other things to monitor is looking for liver problems, GI disturbances, monitoring the growth and monitoring the thyroid function. And rarely, when Octotide has been used in the neonatal periods in babies who are unwell, it's been known to cause necrotizing enterocolitis. So it's important to be aware of this side effects. Now, recently, long-acting somatostatin analogs are available and have been found to be very useful. And they act by binding specifically to somatostatin receptor 2 and 5. There are two groups of long-acting preparations available. One is a lanreotide, which we use in UK, and also sandostatin LAR, which is available in certain other parts of the world. And they work slightly differently. But the net effect is like controlling the glucose, and the effect lasting for up to 4 weeks. So it's the one injection once every 4 weeks, which is really useful for some of these patients. So who do we start these injections? These patients who did not respond to diazoxide, but subsequently known to respond to Octotide. And switch them to the long-acting preparation, the lanreotide or sandostatin LAR. And the dose depends on the type of preparation you're going to use. And if that works, that's great. But if it doesn't work, then the next stage is to plan for surgery. This is for the diffuse patients who haven't responded to diazoxide or Octotide. The last resort is to go and remove the pancreas with the hope that will control the hypoglycemia. But unfortunately, this is not an ideal option because we know post-operatively a lot of patients still continue to have ongoing hypoglycemia. And invariably in the long run, many of these patients, or most of the patients, will end up developing diabetes mellitus because the pancreas has been taken out. And they also need enzyme supplements because of the exocrine pancreatic insufficiency. There are a few newer futuristic therapeutic options available. Some are in trial, like specific somatostatin receptor antagonists and certain somatostatin receptor, not antagonist, sorry, receptor agonists, and some drugs like pasireotide are currently under trial. mTOR inhibitors are being used in certain situations. GLP-1 receptor antagonists have been tried and is being tried as well. Insulin receptor antibodies undergoing a trial at the moment, and long-acting soluble glucagon. Now, the glucagon, which we discussed before, it's not stable in the long run if in case you have to use as a continuous infusion. But there is a newer preparation available as a soluble glucagon, which can be used in the insulin pumps, and it can be run subcutaneously, continuously, and the patients can go home on that. So there's a trial ongoing at the moment, and we are recruiting patients for this trial as well. So hopefully there will be more options in the next few years for managing severe hyperinsulinism so that the patients do not end up having surgery. So to conclude, hypoglycemia, early recognition and treatment is very crucial to prevent the brain damage. And undertaking an appropriate hypo screen in the early stage is important to get to the diagnosis. And if you diagnose as hyperinsulinism, that we know that's the common cause of recurrent persistent hypoglycemia, and appropriate treatment early will help to lead on to a good neurodevelopmental outcome in the long run. So I'm going to stop here, and thanks to all of you for listening. I'm happy to take some questions. So our Global Pediatric Lecture Series is going to run every week, Wednesday, UK time, 4 p.m. And you're very welcome to join. We have a number of talks planned for the next few weeks, and it will alter between different conditions and specialties in pediatrics. And if you want to know more about it, you're very welcome to visit the Alderhey website, the Academy website, or email the email here to get to know more details. Or if you want to leave your email on the chat box, please do. And please do share your questions on the Q&A box, and I'm happy to answer any questions now.
So our first question's from Dr. Parvathy, and they've asked your experience with GSD Zero in children. How is their long-term outcome?
Yeah, it's a good question. So GSD Zero is sort of relatively recognized in the recent years. So they are quite tricky to diagnose, and the key thing is the fasting hypoglycemia. They don't. The problem is in storing the glycogen, so they don't have a hepatomegaly like the other forms of GSD. So the diagnosis is usually through genetics, and the management is through frequent feeds, basically. And sometimes we use the slow release long-acting carbohydrate overnight to avoid long durations of fast. So the key thing is to avoid long duration of fast. If they're unwell during intercurrent illness, then to give frequent sort of glucose or carbohydrate-containing foods. We use something called polycal as a continuous sort of feeds or a frequent bolus sort of feeds to avoid the hypoglycemia.
Thank you. Dr. Aftab has asked, do you suggest hypo screen within the first 48 hours of life? And when is there a phase of hyperinsulinism? He's also asked, just following up, would you then recommend a 30 minutes after?
Yeah, so yes, that's a good question. So there may be a lot of babies do have a transient, drop in blood glucose. It depends on, again, the situation. If it is an asymptomatic baby, then you are going to treat or give some feeds and recheck again afterwards. But if there's a severely symptomatic baby who's having seizures and very low blood glucose or having repeated episodes of hypoglycemia, then yes, hypoglycemia screen should be done early.
Dr. Aftab again, in hypo screen, insulin or C-peptide, which is more significant if detectable?
Yeah, I mean, insulin is the key hormone we're looking for. But sometimes, again, there could be issues with assays with insulin or transporting. So in those situations, C-peptide will be useful. But some assays are quite sensitive for C-peptide, so you may end up getting detectable levels of C-peptide in patients who do not have CHI. So we've got to be quite careful about that.
Dr. Parvathi's just asked for a little bit of clarification. The dose of dioxide in SGA, is it 5 milligrams per kilogram or still lower than how you start?
Yeah, good question. So the standard dose is 5 milligram per kilo per day. But in IUGR babies, yes, over the recent years, we have learned that they can do well on a small dose. So we start like 3 milligram per kilo per day. And that probably might be enough for some of the IUGR babies as well. So yes, we can use lower doses.
I have a question here. May I know why 25% of dextrose needs to be delivered via a central line?
Yes, it's not just 25. Any dextrose more than 10% or 12.5. Sometimes we do run 12.5 peripherally. Anything more than that should go through a central line. If you run anything higher concentrated dextrose through the peripheral line, it will cause skin damage and thrombosis and lots of other problems, and you might causing major problems to the limb of the child. So yeah, maximum is 12.5. Anything more than that should definitely run through a central line.
And Dr. Aftab has asked, in developing countries where dioxide is not available, we are using sandostatin as the first line. What is your experience on adding corn flour in infants less than 1 year old?
Very good question. Yes, diazoxide supply is a big issue in certain parts of the world. You can try the tablets if it is available, but then that may not be easily available as well. You're right. So in those situations, people might end up using octotide injections, which is not ideal. But they might respond to octotide, which may need combining with frequent feeds. And yes, overnight, if they're fasting for long duration between feeds, adding a slow release carbohydrate, corn flour could be tried. The corn flour, the taste may not be great, so babies may not tolerate that well. So that is the problem actually. But if they're able to take it, yes, then that could be tried and added. So they have a sort of steady background glucose to avoid hypoglycemia during long duration of fast.
And just to follow up on that, we've been asked, there's only corn flour in some parts of the world. Is that effective as corn starch? And what would be the dosage you would use? Yeah,
so that's something we have a protocol to follow based on help from our dietitians. I'm happy to share that with you if you want to email me after. So we start at a small dose. Again, how the babies tolerate the dose is the key thing here when we start the corn starch.
Dr. Aftab has asked, what is your experience of giving hydrocortisone to CHI?
Yeah, so hydrocortisone has got no role in the management of congenital hyperinsulinism because we know here the problem is high insulin. So we need to use specific treatment like diazoxide or octotide to control the high insulin. Hydrocortisone will not help to control the insulin. I know historically it's been used as a treatment in those days, but it's not it has no role in managing hyperinsulinism. However, if babies do have additional cortisol deficiency as well, then yes, of course, hydrocortisone will be needed.
Ashley has asked, what DGH Gen Peds follow-up would you recommend for a patient who is found to have an episode of ketotic hypoglycemia during an intercurrent illness, assuming hyposcreen is not suggestive of metabolic or endocrine causes?
That's a good question because this is something our DGH colleagues will be coming across quite often. Yes, so if they're coming with just one-off episode like during diarrhea, vomiting, and you have done the investigations and there isn't anything underlying endocrine metabolic problem, and if it's suggestive of idiopathic ketotic hypoglycemia, you don't have to do anything further. Just we have to reassure the parents and warn them that these children might have increased risk of having hypoglycemia again subsequently if they are unwell. So either parents could start glucose-containing fluids at home and manage that way, or bring them to hospital early on to manage hypoglycemia. But apart from that, when they are well, they should be stable, so there won't be anything more needed. However, if you come across patients who come with repeated episodes of ketotic hypoglycemia, that should be investigated further to looking into rare metabolic causes.
Can glucagon be used in SGA preterm, and when would you start the glucagon in neonatal hypoglycemia?
Yeah, absolutely. There is no age barrier for using glucagon. It can be used in small babies, preterm babies, absolutely. We would recommend you get your diagnosis of hyperinsulinism first, so not to use for every single hypoglycemia because it may not work. In hyperinsulinism, we know because of the effect of insulin, there's a lot of glycogen stored in the liver. And glucagon works by releasing that glycogen. So once you made the diagnosis, yes, absolutely at that stage, glucagon can be started as a continuous infusion.
In critical samples, what should a person do if all hormone, GH, cortisol are low and insulin is normal?
I presume you're saying like the lab glucose is low, so it is definitely hypoglycemia, and so any detectable insulin is abnormal in that situation. Cortisol and growth hormone being low, yes, low growth hormone in the neonatal period may not be unusual, so I wouldn't worry too much. We can monitor the growth of the patient later if there is no other evidence of hypopituitarism. Cortisol, again, if you definitely have a diagnosis of hyperinsulinism, it's been studied and well reported that these patients can have a low cortisol in the neonatal period. So it depends again on the other electrolyte problems and what other features are there to suggest retinal insufficiency. And if there isn't anything, we do sometimes follow that up with a Senniappan test to make sure everything is normal and the cortisol is okay. So it wouldn't necessarily always need any treatment with hydrocortisone.
In those countries where there's no Doppler PET scan, does a simple MRI or PET scan or Octotide scan be of any help?
Good question. Yes, there could be problems with DOPA. It's actually the difficulty in getting the dye. The PET CT scan is available everywhere, but the 18 of DOPA dye is quite, it degrades quite quickly, so it has to be manufactured specially, so it might not be available easily. So doing that scan will be difficult, but we know that is the most sensitive scan for diagnosing hyperinsulinism. MRI is tricky. MRI is more sensitive for insulinoma, but not for focal hyperinsulinism. Octotide scan, again, I don't think that's something which is helpful in this situation. Any other questions? Okay, I can see another question. How to transition the patient on IV Octotide to IM Octotide LAR? Need to overlap for long before IV Octotide can be weaned off. Yeah, so if you're on IV Octotide, I would suggest first you switch to subcutaneous Octotide, which is 3 to 4 times daily, and you can estimate the dose based on the IV requirements. And once they respond and they're stable on the subcutaneous Octotide, then you can switch them to the long-acting preparations at the starting dose. And there are different ways of calculating the starting dose, but we can start with the standard starting dose and then build it up as we go along. The injections will be once every 4 weeks. Any other questions? Just wondering, Jody, whether you're probably muted.
Apologies, so just clicking through. We've got one here, an anonymous question. What is your experience using dextrose in premature baby with hyperinsulinism and hypoglycemia?
Yeah, so again, we have used in premature babies who have definitely confirmed diagnosis of hyperinsulinism. We have used diazoxide without any problem. I think your question probably there may be anxieties if there are other problems like underlying cardiac, or if they're ventilator or fluid overloaded, then there may be a risk, so we have to be careful. But when with close monitoring of fluid balance and electrolytes, it can be used and it can help.
At what age can I start the LAR if the patient is responding to Octotide?
Yeah, so that's again a good question. The initial studies looked into using LAR in more than 3 years of age, but we have subsequently used, and colleagues from elsewhere in the world have used in lower age groups as well, so it can be used in infants as well.
Sorry, I just do have a couple more questions coming through. We have one here. Give me 1 second. ABCCG mutation, positive diffuse variety, refractory to dioxide, controlled on Octotide. Is it possible to be self-limiting, and how would they be monitored?
Very good question again. Yes, so if they respond to Octotide, yes, so that will be really useful to continue the Octotide in the long run, because what we know is even the severe hyperinsulinism patients, as they get older, after several years, the condition actually can get milder. So they may be able to come off treatment, but may take many years. But the key thing is if you can hold them until that point without taking them for surgery, then that will be useful. So yes, if they respond to Octotide, definitely we continue that in the long run. We may have to combine that with frequent feeds sometimes. But we have had patients who come off Octotide treatment when they're like 7 or 8 years of age, even with underlying genetic mutations. So that depends on the individual patient and also the type of mutation they have. But yes, they might come off treatment in the long run. Yeah.
Lloyd has asked, if the insulin level was around the upper limit at the first week of life, would you repeat the insulin level before you start the diazoxide?
Yeah, so it's not just the insulin level which helps you make diagnosis of hyperinsulinism, the whole clinical picture. So if you have a baby with a severe hypoglycemia, a lot of glucose, so any detectable insulin, then you are making a diagnosis of hyperinsulinism and you have to start treatment. But maybe you're asking about a situation where you did a hypo screen, but subsequently blood glucose are all normal and the baby was okay, and you probably got the insulin level later, and then it was just borderline. What we recommend doing in those situations is doing a controlled fast for 6 hours, because all babies should normally be able to fast for 6 hours without dropping the glucose. So, and if you are able to fast for 6 hours, so basically like skipping a feed, and if the blood glucose is stable during the time, then you can ignore that insulin value. It was a transient problem and it has resolved, so you probably don't have to do anything more afterwards.
This anonymous question, we often get asked to see babies with low cortisol after being born hypo screen and end up doing SST, which is very often normal. What is your experience and practice?
Yeah, that's an important question actually. So it's not just babies in hyperinsulinism. In babies, we know the cortisol levels, especially random cortisol levels, can be low. That's again, it depends on the clinical situation. If the baby is unwell as features of hypopituitarism or adrenal insufficiency, then of course, then that should be taken seriously and patient should be managed. But if the baby is completely well, let us say otherwise, and you had a cortisol done for any other reason and you have a low random cortisol, that may be not something necessarily abnormal. However, it's difficult to take any risk at that stage, so we end up doing a standard Senniappan test to make sure the cortisol levels are okay. But yes, that may be just a physiological thing in a completely well baby otherwise.
We have a question here. Do you recommend hypoglycemia screen for absent corpus?
Okay, so you're probably thinking about absent corpus callosum being part of conditions like septo-optic dysplasia, which we know is linked with hypopituitarism. So what you're going to look for there is any pituitary problems. So you'll be looking for thyroid and steroid hormones. And as part of hypopituitarism, these babies can have hypoglycemia. Yes, so of course, you'll be monitoring the blood glucose as well. Whether you undertake full hypoglycemia screen or not depends on the clinical scenario. But if you have recurrent hypoglycemia, then yes, you will end up doing the hypo screen.
We have a question here from Subbu Ganison, and they've asked, do you do an MRI brain scan as part of an assessment for severe hypoglycemia? And if so, is there a time frame? And they've also thanked you very much for your comprehensive talk.
Thank you. Yeah, so we don't really routinely do MRI scans. If they have significant neonatal brain injury, let us say seizures or severe brain damage, then yes, as part of the evaluation, they might have MRI scan to look for the affected parts of the brain which is affected. But routinely we don't do MRI, and subsequently, let us say they're growing up, we just go by the clinical neurodevelopmental progress. I don't think MRI has got any role in monitoring the progress afterwards.
Okay, this looks like our final question. It's an anonymous one. May I know whether we should do IM glucagon stimulation test before we start on IV glucagon? Yeah,
that's a good question. So one of the diagnostic methods is giving an injection of IM glucagon and see if the blood glucose rises above like 1.5 millimole from baseline, and that by itself could suggest hyperinsulinism. But if you're going to use glucagon in a patient who have confirmed hyperinsulinism, there's no need to give IM glucagon first. You can go ahead and start the IV glucagon straight away.
Sorry, you've just had one more question come in. Does very high insulin over 500 indicate anything in particular other than CHI in the context of hypoglycemia? Should they have extra investigations such as imaging? Yeah, good question. So so the insulin levels do not necessarily have any correlation to the severity of the hyperinsulinism. So you can have a transient hyperinsulinism patient with a very high insulin,
or you can have a severe CHI patient with initially just borderline insulin. So the insulin levels do not have any correlation to the prognosis or the severity of CHI. So that doesn't really indicate anything specifically. And also, if you're thinking of conditions like insulin resistance, then usually they have high blood glucose rather than low blood glucose. Okay, do we have any other questions, or we?
That's it.
Okay, great. Thank you very much. Thank you all for joining and asking those wonderful questions. That shows that you're all very well experienced, and hope you found this talk very useful. And as we said before, so we'll be running this every week. So UK time, 4 o'clock every Wednesday. Do visit Alderhey Academy webpage for the joining link. And we'll be running this for a foreseeable future. So please do feel free to join and share it with your colleagues as well. Have a nice evening. Thank you.